Well, a very warm welcome to the 17th International Myeloma Workshop here in Boston. And it's a real pleasure to welcome everyone to this meeting. It's been fantastic. It's been, as the 17th meeting, it's actually broken the record for attendance with over 3,200 attendees, which actually is the highest to date. And it's always worth remembering that actually if you go back to the first meeting, which was held by an amazing man, Professor Tim McElwain in Britain, at Blenheim Palace, no less. The attendance actually was at an inn, but one of the receptions was at Blenheim Palace, just to be precise. And it was literally an inn near Oxford. There were 18 attendees, so that was then. That was in the late 80s, and now is 3,200. So very, very pleased with what a wonderful meeting it's been. I think the real strength of the meeting has been several-fold, but probably the most important has been the scientific content of the meeting itself. And I think in that we've seen fabulous presentations from many really gifted scientists, and also some fabulous clinical data from outstanding clinical trials. I just wanted to share some of the sort of highlights as I see them. I think the highlights have been in immune therapy on the one hand, with continued progress with cellular therapies and the recognition that it's not just about the T cell. We've got a lot of interest in what we call natural killer cells, which seem to be very important in tumor biology, and particularly in myeloma. We've also seen some great new data on the impact of various antibodies, ranging not just from daratumumab, which has done great things when it's added to, example, RVD. It's dramatically improving the quality and depth and duration of responses that are being seen, but also some very nice updates with isatuximab, which is a new CD38 targeting antibody that is actually qualitatively different to Dara, but both very, very good data. And then importantly, we've had some updates on a fantastic new antibody drug conjugate, a so-called ADC, and this is called Belamaf for short. The fancy name for it's GSK 916. But that data was presented by Suzanne Trudel, and it's something we're involved in as well, from the DREAM-1 and DREAM-2 studies. And the DREAM-1 study is what's available. DREAM-2 has met its primary endpoint, but data to follow. And I would simply say that it's a very exciting platform of immune therapy that we're seeing. And then I think the other sort of highlights of the meeting and the debates this morning were really, I think, very refreshing, showing that there is such progress that we can have literally 2 hours of debates about what's best and next in any particular setting. And I think there were real takeaways from it. Number one, the 3 drug platforms are essential. 2, that best treatments can vary, and some of the less new treatments, like RVD, for example, versus the newer ones like KRD. Actually, RVD holds its own very well. KRD is great, particularly in high risk, but you have to be a little careful with it, particularly in the elderly. And I think in that context, we're seeing really nice ways that we can tailor therapy to patients. One of the most interesting controversies at this meeting, where the debate was decisively won, was where will autologous transplant be in 5 years? And for American listeners, this perhaps will not be a surprise. The audience voted solidly 70%, 30%, that autologous transplant would no longer be a mainstay of therapy 5 years from now. That's amongst, obviously 3,200 delegates. So that shows a real shift, because the previous thinking was really that autologous transplant was an absolute mainstay of new therapy for upfront patients. And I think that remains true, that it's a key option in newly diagnosed patients. And I would never suggest for a minute it shouldn't be used. It's simply that there may be other options. And before one embarks on transplant, it may be possible to exploit real benefit from other therapies. And for patients, obviously, the benefits that carries are substantial. We presented some quality of life data, for example, showing that even with new therapies, when you bring transplant into the mix, quality of life drops, and it takes up to 3 or 4 months to recover. That's from randomized prospective trials. So when you have information like that, this really matters to patients. We need to know that we're giving them the treatment they need, but not more than they need, and we're not adversely affecting quality of life. So I think that was another very exciting part of the meeting. And finally, there was some very interesting genetic work that was suggesting that patterns of relapse, or rather genetic features of relapse, according to treatments may vary. And there were 2 presentations, one from our own group and one from the New York group, showing that actually when you relapse after melphalan exposure, the genetics may be importantly different than if you don't get melphalan. Now, we don't know exactly what that means yet, so we've got to follow that up. But this starts to make sense, because it then says, okay, perhaps in some patients we should really not go the transplant route because their genetics may be such that we can make matters even, in theory, worse. So we're very interested in this, and this is an important sort of advance because it suggests that, again, one size doesn't fit all. Patients have choices, and the really good news is we're having a continuum of advances that support it. And it's funny because one of my colleagues was saying, well, melflufen, surely that's just glorified melphalan. And in a sense, yes, I suppose it is, but that's the whole point. We want to keep on making progress. We want to make sure that we are doing better. We want to make sure we're providing patients with drugs with a better therapeutic index that improves their outcome. So in all, it's been a very exciting and a very positive meeting. So another aspect of the meeting that's been very exciting is not just, of course, focusing on the disease, but better understanding the absolutely essential nature of the tumor microenvironment, and importantly also what's called the immune milieu. In other words, the immune system around which the patient, or rather around which the disease sits, and importantly which the patient has. I think this is particularly fascinating because what it tells us is that augmenting the immune system to fight your disease is very important, and it's not a static process. So when you present with myeloma, your immune system is highly compromised. Are there things that can be done to bring that back? Well, they range from obviously therapeutic interventions with new agents, cellular therapies and so forth, to more subtle stuff. The importance of diet, the importance of the microbiome. We heard some fascinating data about the microbiome and how that may impact on the inflammatory milieu that feeds disease. So there was really interesting information in that regard. Now, more broadly, there was an understanding that the immune system from patient to patient changes, and also that the immune milieu in which the disease sits can be manipulated, at least preclinically, to improve outcome. This is particularly relevant in things like CAR T therapy and so on, because whilst we're very excited about CAR T, it generates fantastic response, they don't last. So if they don't last, why? And what can we do to keep them going and maintain the duration of disease control that we'd hope for from such an approach? So a very exciting meeting in that regard.
Thank you.